to let the moderators take it away, and we will see you again here shortly. Thank you very much and have a nice day.
Well, thank you very much. Thanks, Piotr and Bob and Sam and Abbas. My name is Mark Ruel. I'm a surgeon at the University of Ottawa Heart Institute in Ontario, Canada. And I'm speaking with you today from St. John, Newfoundland, essentially almost in the middle of the Atlantic Ocean, where I'll be performing surgeries next week and hoping to perform the first couple of mixed cabbages in the history of this province. So fingers crossed that all the implementation lessons of ISMICS will be helpful. We have a fantastic team here and everyone's very engaged in making this possible. So we really hope that it's going to be successful, and first and foremost that the patients will do well. So welcome to the final day of the 2021 ISMICS Reimagined, and welcome to the Cardiac Masters Session 3A, which is entitled Afib and Revascularization. I'm joined here by my colleague and friend, Dr. Yugal Mishra of the Manipal Hospital in New Delhi, India, who will be co-moderating this session with me. Yugal, can you please tell the viewers what we have in store for them for the next hour?
Thanks, Mark. Greeting from New Delhi. It would be my pleasure to explain what we are going to do in next subsequent 1 hour. We are going to get started with 3 live in-box presentation, followed by a group discussion. Then we will continue with 2 invited talks, then an abstract presentation. Following those 3 presentations, we will have another group discussion. We encourage attendees to participate actively. Please use the Q&A window to write off your screen to ask your question as we go along. Our first live in-box presentation is titled Totally Thoracoscopic Left Atrial Occlusion Concomitant to Endoscopic Atraumatic Coronary Artery Bypass Surgery, EACAB, to be presented by ISMICS President Piotr Suwalski from Central Clinical Hospital of Ministry of Interior and Center of Postgraduate Medical Education, Warsaw, Poland. Over to you, Dr. Suwalski.
So hello from Warsaw. Today we'll operate an 86-year-old male patient, very multimorbid one, with symptomatic multivessel coronary artery disease and persistent intermittent atrial fibrillation, which was complicated with stroke a few years ago. He has a very high CTSNet and Hasbled, which is 6 and 5 points. Actually, the patient was admitted 6 weeks ago with NSTEMI, and the heart team decided to go for inverted hybrid approach. Still, in this such elderly, fragile patient, there is a problem of this complex triple antithrombotic therapy, and we will deal with this, try to deal with this, during the same operation through the same ports, the concomitant AtriClip Pro 2 implantation to occlude the left atrial appendage to reduce his risk of stroke and reduce his antithrombotic therapy. So we open the pericardium now. It's possible actually to go both from beneath and from upper aspect of the phrenical nerve. So as I suspected, it's rather big auricle. So no wonder he had strokes in the past. So now we'll place the stay suture using this endostitch device. So I think it would be optimal somewhere here. I think the entrance is from the ridge here to So the next step is the measurements of the basis of the left atrial appendage. We use for this such a sizer, and we will introduce it through the trocar and try to measure the length of the basis of the left atrial appendage. A bit unusual angle, but on the other hand we see very nice. I would say 45. What do you say? Or 40?
45, yeah.
45, isn't it?
Mm-hmm.
Okay. Okay, so this is the AtriClip Pro 2. So it's a system delivering actually the same clip that we know from the previous model, but it has been improved in terms of few features. So this is the end effector that is movable, and as you can see here, we have the articulation system with two levers that so that you can move the end effector in two planes using those levers, like you see here. This is the movement articulation in this plane and this plane. Here you have the security knob just to secure or to lock the position of the end effector after you adjust the proper angulation. And of course here you have the lever opening and closing the clip, as you can see here. And here you have the security trigger or security lever just to release it after you find the proper position. Release like this. Another interesting feature is that we have no longer a frame here, closed frame, but just two metal holders like this, so that it really facilitates the withdrawal of the whole instrument and the system from the pleural cavity. It's also deliverable through the port. It fits.
Wow. This is the
Yes, we lock the opening here with this green button, and we find the proper angulation. So I'm angulating it towards the transverse sinus.
Yeah.
Now securing the system like this one.
I think you can close.
And now we close.
Yeah.
Yeah. And let's have a look at the echo.
This is perfect.
No pouch at all. Looks very nice now.
Bartek, nagrasz tam?
Yeah, this is nice.
Nagrasz, Dominik, parę? Czekaj, a patrzysz jak my tutaj analizujemy? So now we are happy with the position of the clip. We have checked with echo. There is no pouch, no flow. And so we're gonna pull out the safety wire, the one here, just to release the device completely. So, yes. Like this. We are withdrawing the system through the same trocar, as you can see here. So now we'll move on to the next steps and final step of the operation, which will be the anastomosis Lima LAD itself. So luckily we have a very nice LAD. And now you can see, by the way, how difficult it would be to put it through the mini thoracotomy.
Oh.
So we have just finished off the surgical part of the operation, and the patient will be soon extubated on table. The patient will be soon transferred to the ICU, and I had a good feeling that he had really benefits out of this operation.
Savalsky, our next presentation is another live in VAX titled Double Memory Mixed Cabbage, to be presented by Dr. Firoz Davierwala of University of Leipzig. Unfortunately, Dr. Davierwala will not be present for question and discussion because of some unavoidable circumstances. So over to Dr. Davierwala's recorded video, please.
At the outset, I would like to thank the organizers for giving me the opportunity of presenting this video on double mammary minimally invasive CABG. I have no disclosures. We present a 61-year-old male. The preoperative coronary angiogram showed a significant bifurcation lesion involving the proximal LAD and the circumflex. The right coronary artery itself was okay, but there was a total occlusion of the proximal PDA. We decided to perform a minimally invasive CABG with bilateral internal thoracic artery. A 7 to 8 centimeter left anterolateral thoracotomy is made. A finger is inserted to find the location of the apex of the heart, which should be about 1 centimeter below the intercostal space that is open. The retractor is then introduced to take down the left internal thoracic artery, which I usually take down in a skeletonized fashion. I use the clip and cut technique as seen here and avoid too much of burning in order to prevent development of hyperesthesia. The entire length can be taken down. Here you can see the bifurcation, and here up top you can see the left subclavian vein. And so it's a myth that one cannot take down the left internal thoracic artery completely through this technique. Here you can see the entire length of the left internal thoracic artery, which has been taken down. The next step is to move to the right side. We open the right pleura completely in case we want to take down the entire length of the right internal thoracic artery. A sponge is introduced into the right pleura to keep the right lung away. 3 to 4 pericardial stay sutures are taken on the right side of the pericardial fat, and these sutures are then brought out through a small puncture wound on the left side. And when the sutures are pulled, as you will soon see here in the picture, you can see how the space in the thorax increases, which facilitates the takedown of the right internal thoracic artery. So takedown of the right internal thoracic artery is exactly the same as that which you take down through a sternotomy approach. I usually prefer to cut or transect the vein when we want to take down the entire length. In this case, it was easier to take it down in a sort of pedicle fashion, but still I use the clip and cut technique and keep the burning of the chest wall to a minimum. It is possible here to take down the entire length of the internal thoracic artery. The only difference from a sternotomy approach is that one has to use long instruments. So here you can see it's more than about 17 to 18 centimeters in length. The pericardium is then opened over the right ventricular outflow tract and is extended right up to the ascending aorta. This is to identify the location of the Y anastomosis, which is marked on the leta with a clip. The octopus is then introduced 1 to 2 intercostal spaces below the thoracotomy into the chest, and the pods are covered with a single finger glove, which is used as a platform to perform the Y anastomosis, as you can see here. The leta is fixed onto this glove with a 6-0 proline suture so that the anastomosis can be performed under very stable conditions. The leta is then opened up obliquely in order to perform the Y anastomosis. So I usually start the Y anastomosis on the assistance side at the toe end because this part of the anastomosis is extremely difficult to visualize if it is performed last. So once a few stitches in the toe are taken, the mammary right mammary is parachuted down, and following this, the surgeon side of the anastomosis is completed. This technique gives a clear vision of the entire length of the anastomosis. So here we are completing the heel of the anastomosis, and then we move on to the opposite side or the surgeon assistant side of the anastomosis. So the tying of the anastomosis is always performed once the mammaries are pressurized. Following this, preparation is now made for performing the LITA to LAD, and the pericardium is opened just short of the apex. Do not open it around the apex because it will cause herniation of the heart. So once the LAD is stabilized, it is opened and a shunt is placed into the LAD, and the anastomosis is exactly the same as that for a mid-cab approach. So I usually start from the surgeon's side and first finish the heel. Once the heel is done, the mammary is parachuted down, and following which the assistant side of the anastomosis is completed. Then the toe, as you can see here, and a few stitches are then taken outside in on the coronary artery on the surgeon side to complete the anastomosis. The shunt is pulled out and the knots are tied again under a pressurized mammary. Flowmetry is performed to confirm adequate flows. Following this, the pericardium is clipped and then cut around the apex right up to the phrenic nerve. The clips serve to provide orientation during pericardial closure. So here we see the armless starfish, which is used to position the heart for the anastomosis to the high OM or the intermediate. It is important to notice here that the octopus can also be deployed through the incision, but a 2-point fixation with 2 holding arms is required to do so. So the proximal occlusion is performed with a silastic band, which is performed in this fashion. It's clipped and cut off so that it does not occlude your vision. The vessel is then opened up and a routine side-to-side anastomosis is performed. I usually start at the heel and perform the surgeon side of the anastomosis, as you can see here, for which one has to pass the needle from outside in on the native coronary vessel all along from the heel to the toe. Following this, we switch sides and then perform the opposite side of the anastomosis in routine fashion, and again come up finally to the toe of the anastomosis and onto then the surgeon's side before tying the suture. So the flow measurements are again performed to confirm adequate flows, and then we move on with the operation. So similar to the obtuse marginal, we also use the same technique for the PDA by using this octopus through the incision. And here this anastomosis can either be performed from the surgeon's side or also from the opposite side, whatever the surgeon is comfortable with. So here again you start at the heel, which is the most difficult portion to perform, so that it's well visualized. So once the heel is performed, the mammary is parachuted down, and the assistant side or the left side of the anastomosis is completed. As you can see here, we've reached the toe, and now the right side of the anastomosis is performed again, the needle being passed outside in on the coronary artery. So this can all be performed subject to that the coronary artery is suitable for doing the anastomosis in this fashion. If it's calcified, then one has to go inside out on the coronary and has to alter the technique a bit. So here you can see the completed anastomosis, And once this is performed, flow measurements are performed, protamine is given, pericardium is partially closed over the apex, and the final incision looks like this. It's about 7 to 8 centimeters in length. With that, I'd like to thank the organizers for giving me the opportunity to present here.
Thanks to Dr. Firoz Davierwala. Dr. Davierwala has moved from Leipzig to the Peter Mengs Cardiac Center, University of Toronto. Now we have to move on, and our next live in Vox presentation is the last presentation prior to our first group question answer, and is titled Multivessel Tcab with bilateral internal mammary artery grafts, to be presented by our secretary, Dr. Hussam Walki from the University of Chicago Medicine. Over to Dr. Walki, please.
Good morning. I hope you're enjoying ISMICS 2021 Reimagined. I'd like to thank the Society for the privilege of sharing this live in a box presentation with you this morning. Robotic multivessel Tcab with bilateral internal mammary artery grafts. These are my disclosures. The patient is a 64-year-old gentleman, diabetic, who presents for an elective procedure. He has a totally occluded left anterior descending, a 90% lesion in the first diagonal, and a 75% stenosis in the ramus intermedius branch. This is our setup for a robotic beating heart Tcab, which we have been performing now for about 13 years. We use the Da Vinci SI robot continuously because of the presence of the endo-wrist stabilizer. The ports, as can be seen here, are in the 2nd, 4th, and 6th interspace anterior axillary line. For the initial ports, a subcostal 10 millimeter port for the 4th robotic arm, and a left anterior 2nd interspace port for the working port, which is a sealed air seal at this time that helps a lot. We use a bronchial blocker and a single lumen endotracheal tube. We have been using double CO2 insufflation to protect against any kind of loss of CO2. I've stopped using a Swan-Ganz catheter. All the procedures performed off pump, and we have used an anastomotic connector for the majority of the cases up until about 2018, and now are using a purely sutured approach because of the non-availability of the anastomotic connector. After the ports are placed, the robot is docked, the posterior pericardium is opened for drainage or for exposure of a posterior target, and then the anterior pericardium is opened. The right pleural space is entered, usually at the top of the chest, and the right internal mammary artery is harvested, as can be seen here, using a skeletonized approach. Bipolar electrocautery for the smaller branches and clips for the larger branches, as can be seen here. We move back into the left chest and harvest the left internal mammary artery using an exactly similar approach. The two are really very similar and close to each other when the chest is not open. The subcostal port is then placed after clearance of the endothoracic fascia, and the 12 millimeter sealed working port is placed after that during the same trip back to the table. The stabilizer, as was just seen there, is able to facilitate harvesting the top of the right internal mammary artery conduit. After which it is placed gently on the heart, and as can be seen here, the targets are prepared. This is a left anterior descending, and now this is the diagonal branch. I use electrocautery to minimize on the amount of bleeding during dissecting the targets, and snares are placed easily using this saddle loop snare prior to heparinization. Once all the snares are placed on the targets, we heparinize the patient, ACT about 300, and then prepare both internal mammary arteries with intraluminal papaverin solution using this epidural catheter, as can be seen here. First, the right internal mammary artery, and then the left internal mammary artery. I've been using this approach, was trained as a fellow to do it, and have used it on all my open and endoscopic procedures, as can be seen here. Once the conduits are harvested, we decide who's going to go where. Usually the left internal mammary artery to the left anterior descending, and the rema to the circumflex branch. This happens to be a triple vessel procedure, so we're also going to sequentialize the left IMA to the diagonal. After a short period of ischemic preconditioning, the left anterior descending is opened using the beaver blade, as you saw there in the right hand, and the sharp pot scissors to elongate the arteriotomy. A 2.25 millimeter Medtronic shunt was placed in this case because of the size of the vessel, and it seals it nicely, maintaining flow. This suture technique is using a double-armed Pronova. It's a short stitch, about 11 to 12 centimeters, double-armed 7-0. We start on the far wall in the middle and go inside out on the conduit and outside in on the coronary target, using one needle to come around the heel and then tightening that very tightly because there is no follow. And then picking up the other needle and using that to come around the toe with an outside in the conduit and an inside out approach on the target. We bring the second needle as close as possible to the first needle, leaving some room for the shunt to be taken out. We first flush the conduit and then remove the shunt gently. The suture is then tightened up and then tied using an instrument tying approach. The bulldog is removed, and you can see a nice anastomosis, hemostatic with pulsations. Transit time flowmetry is a must in all of these cases, and you can see here good flow in the lima to the LAD with a good pulsatility index. The second anastomosis now is the right internal mammary artery to the ramus branch, and you can see here it's the exact same technique. We open up the conduit as well as the target, place a shunt, release the snare, provide distal perfusion, and create an end-to-side anastomosis using exactly the same technique. Once this one is done, we check the flow here as well. Looks like it's good. And then we move on to the side-to-side anastomosis between the left IMA and the diagonal branch. And in this case, we're going to be using some softer shunts, which are usually my preference. The chase shunt here, it's a smaller target, 2 millimeters, and we're going to put a shunt in both the conduit and the target and use a similar technique, albeit slightly changed up because of the trajectory, and we take the heel of the conduit slightly off of the heel of the target, but similar concept, and then bring the conduit down as can be seen here. The robot provides for excellent magnification as can be seen. The two shunts are then carefully and gently removed. They're a little bit more flexible than the Medtronic shunts, and then another instrument tying of the stitch. We take the bulldog off and check the flow, which is 111 cc's to both targets. And then finally, the final step is to protect our conduits. This is a deep trough in the anterior mediastinum, which we've created, and then close the anterior mediastinum over the right internal mammary artery graft, and then use the extra pericardial fat to close it over the anterior surface of the heart and the left internal mammary. And finally, the chest is drained with a 24 millimeter Blake drain into each pleural space. These patients are usually discharged within a day or two after surgery. A case like this will probably take us about 5 hours or so to complete. Thank you very much for your attention. I'm available for questions in the discussion session. Unfortunately, we did not have time to present any data, and perhaps we can address that during the discussion. Thank you very much.
Thank you, Dr. Valki. We would now like to open this up to the attendees for discussion. A reminder to all of our attendees, please be sure you are typing your questions into the question and answer box on the right of your screen. So let me put the first question before marks come into the picture. And this question is from an attendee, and question is to Dr. Piotr. Now, what is your landmark for your working port and the camera port for appendage ligation, and also for your endocap? You are on mute, please.
Yes, so thank you very much for the questions, and thank you everybody for being with us. It's another great day of ISMICS Reimagined. Thank you so much. And of course, so first of all, the landmarks for AtriClip, I think it's important to be, lower than you would think with the port when you insert the AtriClip. This is more or less an axillary anterior line, but it's about 5/5 of our 6th intercostal space. Because you have to have in mind that that you need to have a good angle because of the left ventricle to approach the basis of the left atrial appendage coaxially, I would say. So it's important to have in mind. Of course, it can differ between patients, but I think what you need to get at the end is the proper landing coaxial zone to the basis of the left atrial appendage. And of course, also when planning similar access to the Lima takedown, of course, Lima takedown is more, let's say, kind of liberal for planning the ports. So you can, depending on the patient, also kind of play with this and compromise it a bit in between to use the same ports.
Thank you. Let me direct the question to the Mark. The question was to the Firoz Zavierwala. So Mark, the question from attendees is how you decide the distance in a conduit for two sequential anastomosis?
Yeah, thank you, Yugal. This is a great question. In fact, the distance on the beating heart, the beauty is between an OM and a PDA, you can just measure what it is, right? And that's one of the advantages of having a beating heart. Where the distance varies when you're doing complex sequential arterial grafting is between the ascending aorta and the first target on the lateral wall, right? So you always need to leave a longer distance. But once you've landed there, then you can essentially just put the graft where it falls on the beating heart, even if the heart is raised by the armless starfish. So I think this is a very important caveat and dynamic of multiple arterial grafting. Really, the distance between the proximal, if you're going to put it on the aorta, and your first landing zone laterally, you always need to add length. But once you're there, then you can basically measure as it is. And Yugal, I don't know if that's your take as well.
Thank you, Mark. So I think the last question, yeah, you can start now. You can ask questions, please. Go ahead.
Perfect. Well, this is pretty much all the time we have. But I wanted to ask a question to Sam, in relation to what Piro's presented. Interestingly, many attendees will probably notice you start with the right memory. Piro started with the left. I prefer to start with the right. I'm always afraid I'm going to injure the left if I start with the left. What are your thoughts? You've probably gone back and forth between the two,
right? Thanks, Mark, and thanks, Yugal, for moderating this great session. Thanks for our attendees. That's a good question. I always start with the right because when we're bringing the robotic instrumentation and the camera across the midline, there is a small chance that you injure the left. And so I like to finish harvesting everything that we can on the right side and then come back and do the left. And then when we finally separate between the two, I always am cognizant of where and how low the left is lying in terms of potential for injury. It really depends a lot. Sometimes what I actually do is I leave the conduit that we're not using, I leave it up, because you're in, as opposed to a mixed cabbage or a mid cab, the endoscopic environment is always available to you during Tcab. And so in many cases, we'll leave the Lima up and completely attached, work on the Rima, complete that anastomosis, cover it up with our anterior mediastinal fat, and then go and divide the left internal mammary artery and put that on the left anterior descending. Obviously, there's a huge discussion as to which one you do first, which target do you graft, what is the anatomy, and it's the whole beating heart off pump, conceptualization of which graft gets done first. But there's a lot of versatility when you're doing it totally endoscopically, I guess, is the message.
Awesome. So let me ask about the end of, the anastomosis. Like in this particular video, what you did a Lima to LAD first, then yes, you did a Lima to the ramus, and yes, then eventually you did a side to side diagonal to and the Lima. Why you yes did so? Normally, what we do that we finish the first, because so that the LAD Lima is away, and then you can take over the Rima to.
Okay, good question, and I'll be very brief. I know Mark wants to get us off to start the next segment of this, but in this particular case, because the LAD was a CTO, I did the LAD first with the left IMA. And to me, that's a freebie. And, you know, John Puskas talks a lot about how you have to really customize the order of grafting according to your anatomy. And so when you put the Lima on the LAD and the LAD is totally occluded, you've given yourself some great room to have some perfusion, and you're not hurting anybody. And then your ramus or your back of the heart anastomosis becomes a little bit easier. And so you're almost trying to kind of navigate, you know, your off pump approach. And so in this particular case, that's the answer for the order of events.
Great answer, case by case, as is often the case. So I want to thank Piotr, Piros, and Sam for excellent presentations this morning. This is all the time we have for our first group discussion. We're now going to move into section 2 of cardiac section 2B with 2 invited presentations and then 1 abstract presentation. Following the 3 presentations, we'll have a short group discussion as well. So our next presentation is titled, "What would I like my cardiac surgeon to do in CAD, RE hybrid approaches or not?" To be presented by Robert Gill of the Central Clinical Hospital of the Ministry of Interior Center of Postgraduate Medical Education in Warsaw, Poland. Dr. Gill, take it away.
Hi, I'm Robert Gill. Thank you very much for inviting me to this very important and interesting conference where interventionalists can meet and share his opinion with cardiac surgeons. The only potential conflict of interest is the fact that I'm interventionalist. Task for today is just to present you my expectations to cardiac surgeon regarding coronary artery disease, revascularization. So therefore, I decided to change a little bit the original title for what do I expect from my cardiac surgeon. So this slide is relatively busy. The list is not very short. Due to the limitation of the time, I would like to go through the most important expectations or even requirements. First of all, I expect from my cardiac surgeon the fact in the idea of heart team. We know how important is this structure where interventional cardiologist and cardiac surgeon is the core of this heart team. We should take into consideration, we should know and remember that fight doesn't make a sense, but it makes miracles, especially for very difficult, tough patients. This field of cooperation is very important, taking into account a good outcome of our patients. So just to achieve this goal, we should use daily recognized risk scales of cardiac surgery and invasive cardiology, because it gives us so-called holistic approach. It's proposed very well and presented by many scientific societies from Europe and from America. So I truly believe that we should take into consideration during the meetings of heart team the factors that may guide revascularization strategy for coronary artery disease progression. The partnership in discussion and rising above 5 in one's infallibility and perfection is a core moment of good discussion and balanced opinion, which should be paid by the best possible outcome of our patients. We don't present our own feelings and point of view. We should try to find a balance regarding the goal of our patients. I truly believe that my cardiac surgeon should believe in the importance of using cardiological diagnostic methods, invasive and non-invasive. We should expect results of not only coronary angiography, but also much more precise instruments and methods as intravascular ultrasound optical coherence tomography and assessment of intermediate lesions using FFR, for example. I really believe that hybrid coronary arterial revascularization is the best field to meet the best of cardiac surgery and percutaneous coronary treatment, where we can combine the best of these two. The fact in the role and strength of hybrid coronary revascularization, this is next expectations, let's say, from me to my cardiac surgeon. I would like to stress the fact that this hybrid approach is most important for high syntax score patients. Just consider that hybrid approach gives you not worse results compared to classical CBG, but much better regarding pure coronary stenting. We should also be very flexible in terms of sequences of hybrid coronary revascularization stages, taking account the clinical status of the patients and coronary artery progression. And the last but not least, I also expect from my cardiac surgeon the ability to use the latest trends in cardiac surgery by using modern technologies that reduce the invasiveness of cardiac surgery. Tcab has still very good, important role in coronary revascularization, but we should decrease the number of these procedures in favor to endoscopic approach, and much more and more, this is the future, the robotic approach, where we can use not only one internal mammary artery, but also both of them. So let me conclude my presentation by the question, why don't we try to combine the best of CBG and PCI? We know the benefits of these two techniques, we know limitations, and the combination of these two is able to give us really very good results for our patients. So thank you very much for your attention.
Well, thank you very much, Dr. Gill. Along the same lines, our next presentation is titled, What Would I Like My Interventional Cardiologist to Do with regards to hybrid revascularization? And this will be presented by Dr. Nirav Patel, who is joining us from Lenox Hill Hospital in New York. Nirav, the screen is yours.
Good morning, everyone. I'm Nirav Patel from Lenox Hill Hospital in New York City. And Sam Balke and Jorg have asked me to present to you my opinion on what I would like my interventional cardiologist to do for coronary artery disease management in a hybrid program. These are my disclosures. I have no relevant disclosures related to this presentation. So my suggestion to any interventional cardiologist, if they want to be part of the hybrid program, is that you have to believe that Lima to LAD is the best way to revascularize anterior wall. It is better than any kind of stents or any kind of transcatheter therapy. Minimally invasive Lima to LAD in expert centers is equal in quality in terms of graft patency and longevity of the graft compared to sternotomy Lima to LAD. Hybrid revascularization should not be considered as an alternative when sternotomy CABG is indicated, and we'll talk about that later part of the presentation. Hybrid revascularization should be part of the decision tree. Think hybrid every time you're going to do multivessel PCI, which involves PCI of the LAD. So let's talk about some of the evidence. Lima to LAD, is it as good as in mid-cap versus sternotomy? As you can see, this paper, which was published by Mike Halkos and John Pascas from the Emory group, they looked at patients who had sternotomy Lima to LAD versus their minimally invasive Lima to LAD patients. And they had a very good follow-up at 7 years. They looked at MACE events and survival, freedom from survival. And you could see that both groups compared quite well up to 6 years. So we know that Lima to LAD done minimally invasive and expert hand is as good as done through a sternotomy. ISMICS for LAD revascularization comparable to PCI. This was the trial done by Fred Moore and his group. Now, they published the 7-year data where they looked at sirolimus-eluting stents compared to Tcab, and they looked at 7-year event-free survival. Tcab was significantly better than the stent group. But those were sirolimus-eluting stents. We looked at the second generation stents, and we only included patients with complex LAD PCI. And when we looked at our outcomes, it showed the similar way that there was a significant difference in event-free survival in the Tcab group compared to LAD group, PCI group, going out to up to 7 to 8 years. How does hybrid compare to standard CABG? There have been numerous publications, and Sadar and his colleagues did a very nice meta-analysis. This meta-analysis showed that composite outcomes of all-cause mortality, myocardial infarction, and stroke at 30 days is superior in hybrid compared to CABG. And most of these papers were, included in this meta-analysis, were propensity matched studies, apart from one which was a prospective randomized trial. Long-term mortality was not compromised in compared to hybrid versus CABG. Some increase in repeat revascularization in hybrid group compared to CABG, but decreased blood transfusion, ventilator time, and short-term outcomes in hybrid group compared to CABG. We also published our data going short and intermediate term outcome in double vessel disease. So these are practically low and intermediate syntax score. And we showed that the short-term outcomes were superior with faster recovery, lesser complications in hybrid group compared to open CABG group, but without compromising long-term event-free survival. So what I would like my interventional colleagues to do, if you have a multivessel coronary artery disease, please calculate syntax 1 and syntax 2 score. If syntax score is greater than 28 to 30, patient has diabetes, younger patients has severely compromised LV function, patient should be referred for sternotomy CABG. If the syntax score is low or intermediate, then hybrid should be considered if you are thinking about multivessel PCI. If Tcab or PCI is contraindicated, patient should still have sternotomy CABG. If patient is presented with acute coronary syndrome and the culprit vessel is LAD, then Tcab should be done first and the other vessels should be done 4 to 6 weeks later. If the patient has come acute coronary syndrome, but the culprit vessel is non-LAD, then PCI should be done first and 4 to 6 weeks later, Tcab can be done. If culprit vessel is LAD, Tcab gets done first, and then non-LAD vessels should be PCI'd within that admission if that is a critical lesion. If the lesion is not critical, you can wait 4 to 6 weeks. If the patient did not present with acute coronary syndrome, the timing and the priority whether Tcab goes first or PCI goes first depends upon the most critical lesion in terms of severity of stenosis, morphology, if the lesion is thrombotic, and myocardial territory which is supplied. If it is LAD, which is the most critical lesion with severity of the stenosis, then that should be done first. If it is non-LAD, then PCI should be done and mid-cap should be done afterwards. So this is the general algorithm I would like my interventional cardiologist to follow, and we do that at Lenox Hill. Hybrid revascularization, in my opinion, gives best of the both worlds. It gives excellent long-term results. It has very low morbidity and mortality. And most importantly, it fosters a heart trim approach for coronary artery disease. Thank you very much for attention and invitation to present this at our annual meeting.
Thank you very much, Nirav. This was a great presentation. We'll have an opportunity to discuss your and Dr. Gill's presentation after the next talk, which is an abstract presentation by Dr. Witkowska from Warsaw, Poland, which is titled Thoracoscopic Left Atrial Appendage Epicardial Clipping for Stroke Prevention in Patients with Atrial Fibrillation. Dr. Witkowska.
Good morning, ladies and gentlemen. Thank you for the possibility to present our work, Thoracoscopic Left Atrial Appendage Epicardial Clipping for Stroke Prevention in Patients with Atrial Fibrillation Long-Term Follow-Up. My name is Anna Witkowska and I have nothing to declare. As we all know, atrial fibrillation significantly increases the risk of stroke. It's 5-fold higher than in general population. And those strokes are more devastating and disabling. And also, according to SPINAF data, in 15% of patients, we may diagnose silent strokes. Introduction of oral anticoagulation reduced the rate of stroke by 64%. It remains a standard of care, however, it's also connected with significant complications like intracranial or gastrointestinal bleeding. As the main source of thrombotic material in patients with atrial fibrillation, left atrial appendage is pointed. Recently, we also have on the market few devices, few systems for occluding the left atrial appendage in order to block clot formation. According to the latest guidelines for atrial fibrillation treatment, left atrial appendage occlusion is not inferior to oral anticoagulation for stroke prevention. Here, we'd like to present results of our experience with epicardial clipping system for the totally thoracoscopic left atrial appendage occlusion for stroke prevention in high-risk patients with atrial fibrillation. We analyzed 80 patients. 41% were female, in mean age of 67 years. 68% undergone a long procedure. In the rest of them, we also performed the totally thoracoscopic ablation. 27% of patients had prior stroke. In 6% of patients, recurrent thrombus in left atrium was diagnosed. In 11% of patients were disqualified from percutaneous procedure due to unfavorable anatomy. 21% undergone gastrointestinal bleeding and 11% intracranial bleeding, which were also the indication for the procedure. Mean CHA2DS2-VASc score was 4 and mean HAS-BLOOD score was 2. In all patients, we performed transesophageal echocardiography during operation in order to rule out the thrombus in left atrium or in the appendage, also to guide the proper deployment of the clit directly at the base of the appendage. In 50 patients, we also were able to perform control TEE or CT examination 6 months after the procedure in order to assess the effectiveness of the procedure. In early postoperative period, we observed no mortality, no conversion to sternotomy. 1 patient required thoracoscopic chest revision due to bleeding. And in 1 patient, we observed hemorrhagic stroke with mild symptoms. Mean hospitalization time was 6 days. Long-term follow-up reached 25 months. There were no strokes, no TIA. In 1 patient, we observed gastrointestinal bleeding without further morbidity. There were 4 deaths, however, not connected, not related to the placement of the procedure. 59% of patients were off oral anticoagulation. In those patients who were willing to undergo TE or CT scanning 6 months later, we confirmed stable clit position and without stump bigger than 10 millimeters or leakage in 98% of patients. And taking into consideration our results, we may conclude that the cardiothoracic left atrial appendage exclusion with an epicardial system is safe, shows a very high efficacy, and offers a good long-term stroke prevention option in high-risk patients with a low complications rate. Thank you very much for your attention.
Dziękuję, Dr. Witkowska. This was an excellent presentation. So we now have a couple of minutes for questions from the audience. Let me start with one, Dr. Witkowska. What would prompt you to stop anticoagulation in one of your patients who has undergone this? How certain do you have to be that there's not even a small burden of atrial fibrillation?
Well, we stop anticoagulation quite easily, especially in patients who has high risk of bleeding or have a low CHA2DS2-VASc score. Low, I mean 3, 4. It's actually it's high for general population. However, after closing the left atrium appendage, we in those patients we are more likely to stop anticoagulation. However, it's better for me when the patient doesn't have AF recurrence. If the patient has this those procedure as a standalone, I'd rather stay with the OACs or NOACs for long-term treatment, according also to the guidelines from European cardiologist recommendations. This is my answer.
That's great. Thank you very much. Question for Dr. Patel and Dr. Gill. So when considering hybrid revascularization, obviously diabetes is an important factor to consider. If you have patients with multivessel disease and diabetes, there's already very strong evidence supporting that the syntax score has 0 impact. If you have that combination, those patients should probably get CABG. And I'm not sure we know about the hybrid revascularization results in those patients. There will also be some data showing that syntax probably doesn't even modulate the benefit of CABG over PCI in any group of syntax scores. But let's start with the diabetes. Dr. Gill, Dr. Patel, how do you see diabetes affecting your decision to consider hybrid versus full sternotomy CABG?
Well, the way we approach, at least my interventional cardiologist and us, is that we look at, there are diabetics with that diffuse diabetic disease. I think those patients definitely do better with open CABG, and we don't consider hybrid on those cases. There could be some diabetics where we feel that if you still can do multi-arterial grafts and you still will do bilateral mammaries, at least to the left-sided circulation, then we tend to err towards going open. But if it is, even though patient's diabetes, but has focal lesions in the non-LAD territory, then we still consider hybrid. I know we don't have evidence. I think the hybrid evidence for hybrid in a level 1 evidence is not going to be possible. We tried to do the hybrid trial. We were not able to enroll enough patients. And that's always going to be difficult, but that's how we are doing, at least our current practices.
Dr. Gill, the closing minute to this excellent morning session. We have 1 minute left for your wise comments.
So my personal feeling is that diabetes shifts the decision in terms of a hybrid approach for multivessel disease in the cases where heart team agreement regarding the development of atherosclerosis, anatomical cruces of arteries, gives option, let's say, for percutaneous treatment, because it's not very rare in this kind of cases, especially in patients with low ejection fraction, with additional kidney impairment, that cardiac surgeons ask us to do this non-LAD part by percutaneous treatment. So this is a very special group of patients. This is not automatically yes or no because of diabetes. This is a very long-term discussion taking into account different scales and also interpersonal interpersonal relationship, because this is very important to believe what cardiac surgeon.
Well, these are
promise.
great points, Dr. Gill. I think this is all the time we have left for the group discussion, but thank you all to all the presenters for really a wonderful session. And to all of you who participated in this session. We're going to turn the program over to our live studio host, Dr. Mishra. Thank you so much for co-moderating this session. Any 2-3 words of closing? And again, thank you all for attending ISMICS 2021, a wonderful meeting, and with a special Polish flavor which we all enjoy. Dziękuję and thank you, merci.
Thank you, Mark.
Thank you very much.
Welcome back to the studio. It's another terrific day, start to the wonderful third day of our meeting. The concept regarding diabetics and revascularization continues to be an issue because unfortunately, despite all studies, we're not just not following guidelines, but I think yet to be discovered. But anyways, as we have mentioned before, this meeting would not have been possible without the support of our wonderful industry partners. And we're extremely grateful for their support.